Hello. Hello. Hello.
We can hear you, sir.
Hello.
We can hear you, sir. Please do go ahead.
Good evening, everybody. I, Dr. Sunil Kotwal, President IAOHNS, welcome you all on the sixth webinar series. Today, the topic is difficult scenario and the voice disorder. Today, the program will be started by on the important, very interesting lecture by Dr. Michael Pittman, which will be followed by the panel discussion. And the moderator for the panel discussion will be Dr. Nurpur Nirurkar. I know I hand over the proceedings to Dr. Nurpur.
Thank you so much, Dr. Kotwal. I'd like to thank the Indian Academy opportunity today, Columbia University Medical Center, Director of the Voice and Swallowing Institute of Columbia Doctors. Dr. Pittman is also the current president of the American Bronchoesophagological Association. He has a wealth of experience in basic as well as clinical research in laryngology. And so, of course, I'm sure we're going to be in for an academic treat in neurolaryngology today. His specific topic is decision-making in unilateral vocal fold paresis and paralysis. And also audience questions are welcome not only at the end of the talk, but even during the talk. Dr. Pittman is going to be asking for our opinion and what we would do in this situation. So it would be very nice if all the delegates also sort of use the chat box so that we can keep it as interactive as possible. Dr. Pittman, well, thank you so much for being with us today. And may I request you now to sort of share your screen and audio and take it from here. Thank you.
Okay, you can all see me and hear me, I assume?
Yes, we can.
Great. All right, Newport, thank you very much for that introduction. This is really exciting for me. This is definitely a little post-COVID situation, giving a Zoom here all the way over to India. It's wonderful. So this is not as much of a lecture as just an extension of the cases that we'll be doing that are difficult. And, I didn't pick specific cases from like the last 10 years, but stuff that I've just seen over the last, say, 6 to 12 months that I thought were interesting and were slightly different than your typical, very straightforward vocal fold paralysis or vocal fold paresis. And I'd like to see how you would handle, what you think of these patients, how you would handle them as well. I'll let you know how I handled them and what I thought were in each aspect, some very specific pearls to look for when caring for these patients. So I think it's really clinically important and not just basic science or discussion. So this is the first patient. She's a 38-year-old paralegal presenting with a known vocal fold paralysis diagnosed from an outside provider. And paralegals have a very high voice demand functioning next to their lawyers. She noticed a voice change 2 years ago after an upper respiratory infection. The voice is very high-pitched, it's breathy, it's difficult to project. When she talks a lot, she starts to get some pain and significant strain.
3, 4.
A significant strain. She has not had any preceding surgery in the neck or chest and no intubation. She does cough with thin liquids several times per week, but no other significant dysphagia. And this is her voice.
1, 2.
Oops. Hold on.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
I want you to take a deep breath in and hold E as long as you can.
Right, so you can hear that, right? So thin voice, almost like a child's voice, high-pitched, breathy, and we use that maximum phonation time as a corollary for glottal incompetence, right? So she could only say E for a couple seconds there. She did have a CT scan of the neck and chest that was normal without any pathology. That's, you know, for us, that's the only workup we do for a vocal fold paralysis, nothing else. I only do it when it's a complete paralysis. So I don't bother with any imaging if the vocal fold is moving. Actually, Mike Johns did a great paper on that, looking at hundreds of patients when he was back at Emory, that didn't show any pathology in those patients. And this is the stroboscopy.
Say E and sniff in between. E, sniff, sniff, E, sniff, E, sniff. Good.
So does anyone want to weigh in on the particularly important parts of this stroboscopy here? Anything? What does anyone see?
Michael, can you play this video again one more time, please?
Yep.
Say E and sniff in between. E, sniff, sniff, E, sniff, E, sniff. Good.
So any thoughts
I
on this?
have some initial thoughts on this. One is that we do see a good arytenoid symmetry on phonation with a little bit of a spindle phonatory gap, not too much of a level problem. So, of course, now she's 2 years out, but of course, if she wasn't, my first thing would be an injection laryngoplasty would really help her. The other thing I noticed is a lot of pooling in the pyriforms, but that can occasionally happen if she's received a lot of lignocaine. But you did say that occasionally she coughs with drinking water, though there's no pneumonia. So I would want to actually do, you know, the sensory tests and see how that is, you know, how the laryngeal adductor, etc., is, how the laryngeal elevation is. And then again, the medialization would probably help with the swallowing tube, building up the subglottic pressure. So I would do now at 2 years, not an injection. Thoughts, and I'd love for the other panelists also to sort of give their opinions, please.
Yeah, I think in addition to that, the tone is not very good. Actually, you can see that when the right vocal cord is trying to close, the left actually moves away. There is lack of bulk as well as lack of tone. And there is gap both at the anterior two-third and even at the vocal process level. Right ventricular band slightly adduct. And as you told, there is pooling. Yeah, with injection laryngoplasty at the same time. I actually inject hyaluronic acid at the same time. That's for the immediate benefit. I will actually tell them that there is a possibility that if it doesn't work in 6 months, I may have to do a thyroplasty.
So you guys hit exactly the points why I actually chose this patient. So let's look at it one more time after hearing that interpretation. And I think you notice there is a lot of jostling of that arytenoid, right? It's not very strong, like JK said. So there's not a lot of tone there. It's extremely atrophic. There's almost no tissue in that left vocal fold. If you look, there is no pharyngeal squeeze in the left. So this is a high vagal injury, even though it's probably a post-viral injury. And that's why there's a dilated piriform and that excess mucus there. And her increased risk of aspiration is not just a straightforward recurrent laryngeal paralysis. So my go-to for years has been for this a type 1 laryngoplasty with a retinoid reduction, because you'll get good medialization. There are a number of papers, especially with Dr. Woodson, when there's significant dysphagia or high vagal injury, that an retinoid reduction will help with swallowing, at least somewhat. I do think that, you know, when we do medialization for patients with voice and swallowing issues, we will help the voice, but I could never know who it's going to help the swallowing. Some people can have very bad swallowing problems, and they'll do great. And some people have mild swallowing problems. It doesn't help at all. I do think that, like Dr. Nupur said, is that if you can close the vocal folds, when you go to swallow, you don't leak pressure down into the trachea, so that you will have increased pressure in the pharyngeal. In the piriform sinus is helping open the UES. But specifically for this patient, I agree with Jakey, where I did a reinnervation on this patient. And the reason is because that vocal fold is so thin. So in my experience, when you medialize a vocal fold, and I use Silastic usually for vocal fold paralysis, and Gord, don't think how good you are. So it's a tool, and whichever tool you like. So I think you can do either one. But for this patient, the vocal was so thin, there was almost no muscle on that vocal fold, that if you put an implant in, I think it's going to impinge on the vibration. And you're not going to voice no matter what innovation. And I think it was only about 2 months. So we don't have the full, because hopefully she's under the age of 6. Well, about 98% chance that's all she's got. Doesn't work. Her laryngoplasty will be better. I will typically wait 9 to 12 months before calling a reinnervation. As you can have a laryngoplasty or an answer reinnervation. This is the patient I think that really the issue. And so we'll see how she does over time. Now, I did not have a lot of experience with reinnervation until one of my, I called some of my colleagues to do these. Sometimes, not all the time, we're not still doing thyroid. So, but one of my colleagues mentioned putting in a bougie. And so now when I do these, I put in an esophageal bougie in first. You'll groove a lot more.
Just
yes. No, to see what that sensation is. But I think actually this is a vagal neuropathy again, and she's absolutely better with the laryngoplasty at that time, and if we just went with the laryngoplasty straight up front, because she'll have more bulk. And when you have a vagal paralysis, regardless of what you hear on the table, I think you should always add that retinoid deduction.
Perfect. I think we have Dr. Handa also who's joined us, but this is, yeah, please. We just have
Good evening.
Dr. Pittman's talk going on. That's
okay. So let's move to the next one. And that bougie is a wonderful little pearl there. I love that. Okay, so this is a 63-year-old attorney presenting with voice concerns. This is an inability to project and vocal fatigue. A gradual onset over a number of years with progressive worsening, denizing dysphagia or dyspnea. And the reason why this is interesting because he's had a number of laryngoplasties already. So he already had a bilateral type 1 laryngoplasty that was a failure. He did voice therapy and failed. Then he had a revision type 1 laryngoplasty with Silastic 5 months before me seeing him, and his voice got worse, was more strained at footfall. And I still don't know why, but he still thinks that alcohol and Xanax help his voice. Here we go.
The rainbow is a division of white light into many beautiful colors. These take the shape of a long round arch with its path high above and its two ends apparently beyond
There's
the horizon.
strained, poor airflow, poor volume, it's very rough. Here's this strobe. All right, so I'm gonna play it again, and then if you guys chime in. So what I see is these implants are huge, right? There's a very small gap. That actually most of the medialization is below the vocal fold edge. You can see it's in the infraglottis. So down here, you can see my pointer, I assume. When it should be, the medialization should be, yeah, the medialization should be here, but it's below. And so unfortunately, this patient needs another revision, okay? And not only is it too low, but laterally there's also a lot of fullness, and so there's an impingement on the mucosal wave. So there's a number of problems here, and it's hard to really play with big silastic implants. That's why when I used to do silastic, and then I learned how to do Vortex, and then I much prefer Vortex for mobile vocal folds, and only silastic for. And I think the silastic, or you can manipulate them more, you can be more specific, but they're harder. So I think they are great for vocal fold paralysis, but not paresis. So I revised this, and I actually just took out his implants and then cut them down and made it much smaller and decreased the implants to 5 millimeters. And as I took down the lateral side, I actually moved up the medialization a little bit to 3 millimeters, from 3 millimeters more, which is a big difference. Like that's a huge change by elevating by 3 millimeters. And here's his voice afterwards. Not perfect, but much better.
The rainbow is a division of white light into many beautiful colors. These take the shape of a long round arch with its path high above and its two ends apparently beyond the horizon.
Good. So patient's chief complaint after laryngoplasty that goes wrong is strain. And now you can hear he can speak fluidly. He's still a little bit raspy, but he's not pushing. He's not fatiguing by the end of the day. And so this is a real win, but he's still raspy. So I want to show you something that we've noticed with patients sometimes, and I have no idea how to fix them. And I've presented patients like this. We do something similar to this once a quarter in New York, where all the laryngologists and voice therapists and speech therapists come. And I presented patients like this, NYU has, and put them under high-speed video. And I just want you to see it. So watch right in the front here. Every once in a while, you'll see that there's a diplophonia. And that's where his roughness is. And I don't think we have the ability to finely tune the vocal folds to actually fix this. We try our best with voice therapy, but it doesn't necessarily work. So watch right up front every once in a while. Say E. So obviously the vibration is much better than it was in the utilization. But right here, see a little fluttering? Right there. Not down. It's gonna happen again. Now you see it, right? It's almost like a double. And and that's his diplophonia. And so I think that's a really important video. I'm going to show it again because this is one of the things that we don't have an answer for. And pretty much after voice therapy, I told him, you know, you're much, much better. Everything's working better, but you're going to be stuck with the intermittent diplophonia. And I just want you to see it again. Say E. Yeah. And then it gets smooth. You won't see it. That's normal. Oops. Say E. There it is up front. Like a skipping. Let's say. I'm an ooh, the voice smooths. Good. Now going back into your other. And then back to E. And see it again. That little skipping right up front there. All right, so that's really the pearl of this one. And so we're still, you know, dealing with him, trying to get him as good as possible. Any comments on that until before we go to the last case?
Yeah, Michael, I did have a question and a comment too. I probably missed it, but the indication was presbyophonia.
Yeah, so by the time it got to me, the indication was massive implants. But he started out as a 63-year-old with presbyophonia.
Because in the video I saw, I did see like a very thin slit of a sulcus on the right vocal fold, but I wasn't very certain what the indication was. The other thing was there was a question from the audience as to why, what is the curvature that we see on the implants. I think what you described as the large implants which had been placed earlier, which caused that kind of concave appearance. And there's a question from Dr. Gautam Khond about alcohol, but I don't think, Dr. Khond, that we discussed alcohol responsiveness in this case. Did you, Michael?
Yeah, he said, for whatever reason, he says that alcohol and Xanax make his voice better. I think it's because
Spasmodic also?
he's an anxious person. It's not because of any neurologic issue.
Okay, all right.
Whatever reason, we can't duplicate that in his therapy. So he failed that, and we don't have time to get into it. But I do think the vocal fold edge is a little bit stiff. So the last thing I offered him, I don't think he's going to get any better. It's just we could put a little steroids in the vocal fold edge, see if that helps smooth things out, and maybe changes the tension slightly and gets rid of that diplophonic jumping in front at the anterior aspect. But I don't think it's going to work, but I offered it to him just to give him something. But I think the real take home is noticing the diplophonia there. And you can actually see it on your strobe. Yeah.
And now my real question is, when I get these revision cases, the challenge I face is very often, like you mentioned, the window is maybe too high or too anterior, posterior. And when you go ahead and correct it, you land up with a window which is much bigger than what you typically make. And so you also mentioned for mobile vocal folds, you prefer Gore-Tex as opposed to Silastic. So I would imagine with a really large window, that is a huge problem with Gore-Tex, because one of the techniques there is to go with a smaller window rather than larger. How do you sort of handle it? Just take a stitch, or what do you do?
Yeah. So it depends on the revision that's necessary. So if it's a Gore-Tex, typically it's at the right height. Hopefully, if it's my personal revision, I put it in the right height. This was not, I wasn't the one who did the first two on this patient. But if you actually have to do a significant revision to change the height, you can't put in Gore-Tex again. You have to go with the Silastic, because if you take Gore-Tex out and you put it in, no matter where you put it, it's going to drop to the bottom of that pocket. And so you're going to always be too inferior. And so I take out the Gore-Tex and then put a Silastic in, and then you can, because the Silastic lets you move around the medialization anywhere and still keep that key that we use and hold it into the implant, into the larynx. I'll always go with Gore-Tex.
Okay, so I think that's a great take-home for us. Yeah. Okay, great. Thank you.
All right, so last case, got a few minutes. This is, I found pretty interesting. This is a 71-year old musicologist and choral singer. Very obsessive compulsive person about his voice. Very obsessive compulsive. He had a resection of a right glomus jugulare in July 2022 with a mandibular swing, and also had a sacrifice of the hypoglossa with a neurorrhaphy. So he had a loss of power and range and hypernasality, and most importantly, unfortunately for someone who's a professional musicologist and singer, he has a right vocal fold, right tongue paralysis and paresis. So his articulation's off a little bit too. His dysphagia of the solids, and he's got horrible VPI, both when he speaks and when he drinks liquids.
The rainbow is a division of white light into many beautiful colors. These take the shape of a long round arch with its path high above and its two ends apparently beyond the horizon. 4. Hold
Perfect. Thank you very much.
for 3 to 5 seconds.
So he you can hear that he's very breathy and weak. You can hear some of the dysarthria, and you can also, I think, hear the hypernasality. And here's his stroke. And look at his palate. It's got a huge gap on the right side.
Say it again. Mama, mama. Mama, mama.
He's got some residual inflammation, movement on the left, but he doesn't come close
And
to close.
Good. Say Donna, Donna.
Donna, Donna.
Good.
And you see he also has a dilated piriform on the right, just like that
And
first
say
patient.
grrr.
Not a lot of tongue function.
We're gonna go E.
And this is for pharyngeal squeeze. You do that high pitch.
Good.
Just on the left side.
Okay, take a break for a second. Now I'll have you say for me, hee hee hee. Hee hee hee. And
But
again.
he's got decent tone, this patient.
One more time.
And he's a bit older.
Good, do that again.
All right, so what's some of the recommendations from the panel here? Does anyone want to weigh in on how it might be a little bit different for this patient? Actually, for time's sake, I'll tell you. So this is the patient where I would do, as we said before, a type 1 laryngoplasty with a retinoid adduction right off the bat, because he's older, so he's not going to reinnervate as well, is one. And then 2, you need to put the retinoid adduction in because he's so weak. It will help with hopefully aspiration, improve his cough, improve his swallowing. There's a better chance, even though you don't know for sure, okay? But for him, probably one of the most important things, this is someone where I do a palatal pharyngeal flap. And this was described by Netterville. You're making a through and through incision in the palate. And the picture he has here isn't great. It starts at the midline and goes a little bit lateral, but you need to go more lateral. You go as far lateral as you can in the palate. And it really doesn't feel good to do this because you're doing a through and through incision in the palate. The palate's just sort of hanging there. And then you're doing the same incision on the posterior pharyngeal wall. And then you need to elevate superiorly and inferiorly off the pharyngeal wall a little bit so that you can pull this forward. And then you throw these matcher sutures. I usually use an ophthalmology needle, the really curved needle that they put in laterally. And evert these and suture it together. And so you suture the palate actually to the posterior pharyngeal wall. And that's to help the VPI. But not only are you helping the VPI, but you're also helping the voice because you're not leaking when you phonate, okay? And you're not only going to help the voice, but you're also going to help general swallowing, again, because the pressure when you swallow goes to the area of least resistance. So instead of going up your nose, it's going to go down and open the UES. And this is what it's supposed to look like when you're done here with and it really should go as all the way lateral. And then this is ours. This is immediately post-op, 1 week post-op. And there you can see the palate completely adherent. Okay, on the right side here, a little bit pulling some mucus.
Do that again.
But complete closure of his velopharyngeal insufficiency. All right, and then this will atrophy a bit over time, and that's why you need to be a bit aggressive with the amount that you're doing. Okay, and then here he is, 9 months post-op, and he's actually singing.
The rainbow is a division of white light into many beautiful colors.
A little dysarthria, but the voice
These
is great.
take the shape of a long round arch with its path high above and its two ends apparently beyond the horizon.
yell 1, 2, 3 as loud as you can.
1, 2, 3.
Right. So I think he was showing off a little bit, right? So his maximum phonation time is excellent. And here's the 9 months post-op. So you have a little atrophy, but that's where he's ending up. Full closure. Great. Breathe in. And say E and snip. Do that 3 times. E. Snip. E. Snip. Good. Now just give me a nice long E. Full closure on phonation. With no impingement like we saw that earlier patient, right? It's good, normal mucosal wave. Normal motion. Good, and then mid-range without any vibrato.
The rainbow is a division of white light into many.
That's it.
Wow, what a fantastic outcome you gave the third patient, especially. I think that's really incredible with the nerve injury at 3 levels and, having that kind of a good closure, especially at the level of the soft palate. I think that's incredible. I've seen that go wrong sometimes with, as you said, one should be a little more aggressive, but I've seen it end sometimes with a complete closure in patients, which then
That's
is
bad.
then that's a problem to keep it canalized and open. But I think that was incredible. And do my colleagues have any questions on any of the cases? Maybe we can stop the screen share and we can just have questions addressed to Dr. Pittman.
Oh,
I'll
Yeah.
also see the chat box. Yeah, go ahead, please.
Yeah. Hello, yeah. Michael, great result, yeah, with that kind of multiple level nerve injury. But I just wanted to ask, when we are doing a retino-rotation thyroplasty and a pharyngeal PECC, did he have some problem with the snoring post-operatively?
no, like there was no stridor post-operatively, no problems snoring.
No, snoring. I mean, not stridor, snoring. Snoring.
No, snoring. No, he didn't have any issues. You mean immediately when he was swollen or just period afterwards?
Okay. And I was thinking one other option now, but this is fantastic result. I was thinking of doing a sort of an injection pharyngoplasty at the site of the palate so that the posterior wall could be augmented more anteriorly.
Yeah. So great point. So two things. One, when I do this, I first do the laryngoplasty, then I put them to sleep and just intubate them gently with a small tube and do the pharynx, right? So I think that's an important, just like Pearl, that you do the pharynx second. And then I've been doing those palatal injections, and actually Apoorva Ramaswamy does a lot too, mostly in post-radiated patients. Have had great success, but only for a few months at a time. Especially this guy had a huge port, so I don't know if it would work. The other thing is I've been doing it mostly in radiated patients, and that might be one of the reasons why. Because I would never do that flap in a radiated patient because it's going to fall apart, right? So those are the patients that would do the injection, like you're saying. So, but there are 2 bad complications you can get. There is a paper on a patient who actually got an intracranial abscess that Dr. Murati published, and has a long-term feeding tube because of it. And then if you do them, especially in radiated patients, they can get severe inflammation and infection. So Apoorva, and I've done this in mine now, they all get steroids starting the day of the injection, which I do in the office actually, and antibiotics for a week, because it can be really impressive. And there have been a number of patients, I unfortunately haven't had one, had to be intubated overnight and watched. And so, and again, we're talking mostly radiated patients. And so I'm trying now fat instead of calcium hydroxylapatite. Maybe that'll be better taken. So I think that's evolving, but it is a great tool in our toolbox. I think we just haven't completely figured out how to use it.
JK, are you using fat or because we don't have calcium hydroxyapatite? Do you use fat?
You're talking
for the
about
Pasava's ridge creation.
Yeah, I use fat, not the thing. So the problem with the fat is that the resorption is unpredictable.
Yes.
So sometimes it get totally absorbed off. But being a less invasive procedure, I would have gone. And again, I would because this procedure, the netroless procedure, I was not familiar. What I would have done is actually what is the pharyngeal flap repair. See, means I take a superiorly based flap from the posterior pharyngeal wall and connect to the posterior aspect of the soft palate. Again, as Michael told, there is some time, and at the time of the surgery, the flap will be quite bulky. But sometimes later, they become narrowed and the hypernasality come back. That problem is there. So in that way, this surgery looks wonderful.
Michael, any reason why one can't do it as a staged sort of thing? Because you're doing the surgery in LA first and then taking them in GA. So would you consider also staging, or is that not a good idea?
I mean, you can, but the thing is, if you know he's going to need it, right? And also sometimes they might get a bit better, and then you're like, all right, it's good enough. Let's
Okay.
not do the, so he's asleep. I think just do it all, right? And then his result, I know that his voice result is so much better than it would be with the exact same, implant and retinoid reduction. I think the voice is much, much better because he's not leaking. So I don't see a reason necessarily to stage it unless it's very small VPI, but they're going to be, it's when you get that vagal injury, it's pretty large. JK, have you had any problems with your injections in the posterior pharyngeal wall? Any complications or inflammation or anything like that?
Fat injections, he means.
No, I inject only fat.
But have you seen any inflammation or
nothing? With the fat, nothing. No.
And have you done it in radiated patients also, or no?
Irradiated patient.
Yes, I'm seeing it mostly in patients who've had radiation.
No, I haven't injected in an irradiated patient.
Yeah. Okay.
And I wanted to ask what was the result of that hypoglossal neurorrhaphy? The tongue was much better.
It's like a little better. You could tell he still has dysarthria. It's definitely a little bit better, and it's not, and he has a little bit of tone there, but it's not nearly. It's never going to come fully back. Yeah, it's okay.
But it's actually a super result with 3 nerves gone.
Yeah. Incredible, I think. I don't blame him for boasting. He did so well.
No, just a small comment. We have done an irradiated patient fat injection. Sometimes radiation fails, but the lesion is still T1 and you resect. I think it works well, except some difference in the pliability of the cord because of post-radiotherapy. Otherwise, I don't think there is anything which prevents us from injecting fat in an irradiated patient.
I think, Dr. Handa, we're talking about the posterior pharyngeal fat injection, not in the vocal fold.
No, I'm talking of the caudal. The posterior pharyngeal, I have no experience.
Yeah. So in this case, we were talking in context.
Right. Okay.
Any other questions from the audience or panelists?
I'm just going to share this last slide just in case anyone wants to get in touch. Here's my email. Okay. So it's pretty
perfect.
Pretty easy. One T in Pittman, everyone messes that one up. There you go.
I think, Michael, this has been actually a fantastic interactive session. I really like the way you presented the cases. It made it more fun for all of us to get our gray cells also in action. And since you've given your email ID, if there are more questions, we will address them, direct them towards you. But thank you so much for taking your Sunday morning off with us, and look forward to more interactive sessions with you in the near future. And Dr. Pittman is the president of the ABEA, and I know the meeting is going to be held in New Orleans in April. Michael, would that be correct? So
April, May. Yeah, April, May.
April, May. And
May. Yeah.
We're also encouraging international new recruits and new fellows. So, if you want to consider applying to the ABA, people who are doing work in, especially in airway, and I know there are so many in India, this is something maybe this year we would really like to encourage, because Michael is the president, and so just reach out to him, me, and we would love to have more people take part in the ABA more actively. So thank you so much, Michael, and have a nice Sunday ahead of you. And
all right. Thank you. I'm
Thank
gonna
you.
hang around a little bit because I want to see
Perfect.
what other things, interesting cases you have. And thank you for the plug for the ABA. Yeah, we'd love to have everyone. And obviously New Orleans is like a special city. It's not just your typical Chicago. It's a really interesting place for music and food, and it's really iconic. So hopefully, if you're coming, let me know ahead of time.
Perfect. So if you're going to be hanging
Yes.
around, we may just pick your brain also as a panelist. And so we're going to move ahead now with the panel discussion, and I'm going to go ahead and share my screen. But before I do that, can I have all the faculty members put their video on? I just want to click a photo of all of us who are part of it. Dr. Vijay Krishnan also. And in case we have the president also, Dr. Kotwal, just so that I can take one quick photo. Okay, thank you. I'm going to go ahead and share my screen now. I think hopefully you're going to be able to see that.
Yeah, we can see it.
Perfect. Okay. So we're going to be talking about difficult scenarios in voice disorders. And we have the creme de la creme of laryngology from India and of course, Dr. Pittman. So we have Dr. Amitabh Roy Chaudhary with us from Kolkata. He is a senior ENT consultant who has a special focus in laryngology. He's been the past president of the Association of Phonosurgeons of India. Welcome, Amitabh. We have Dr. Gautam Kaunt, who is from Guwahati. He's a senior ENT consultant with a special focus in laryngology, and he is also the current vice president of the Association of Phonosurgeons of India. We have Dr. Jayakumar Menon from Tiruvananthapuram, who's a senior laryngologist, focusing now more in neurolaryngology. He's the founder, vice president, and also a past president of the APSI. And he has the Dr. Jayakumar Laryngology Institute group, which he now heads. And he's trained a lot of juniors under him. We have Dr. Kumud Handa with us, who is the head of Department of ENT in Medanta Hospital in Gurugram. He is the founder, secretary, and the past president of APSI, and he has a very keen interest in laryngology. And finally, we have Dr. Brigadier Rakesh Datta, professor of ENT, who's working in the Armed Forces Medical Services. He has a special interest in phonosurgery, and he's also been a journal editor. He's currently working in AI and digital health initiatives. And hopefully we have Dr. Pittman with us for a while also. So we, again, just want to mention in here a plugin to please put in questions whenever you can into the chat box. So we'll make it more interactive, basically. And we will take questions after the panel, or if you find something you want to ask within, please do feel free to do that. So this is a lovely photo of where South Mumbai and where my hospital, Bombay Hospital, is. We'll start with the ear situation where you take the patient up who's got a lovely long thin neck and you just see this arytenoids and you do your best, but you're just not anywhere near the vocal folds. So if I may start with Dr. Gautam Kaunt first, if you can share your tips and tricks as to what you do in this situation where you're just not able to expose the larynx.
Yeah, thank you, Nupur. First of all, sometimes we are in a hurry after intubation. We immediately go in. We have to let the muscle relaxants act. And then once you know the muscle relaxants have acted, then you go in with a scope and you are getting this picture. Then maybe we have to go for a smaller size scope and try to negotiate and maybe change the position of the patient. Normally we do it in a neutral position. Maybe we'll have to think about giving a little extension, maybe the traditional way of putting a little bit of sandbag under the shoulders and extending the neck to get a better view of the vocal folds and trying to generally. And also one thing is about the size of the tube. Even though she has a slender neck, her larynx is smaller in size. So maybe the size of the tube can also matter, reduce the size of the tube.
Okay.
And if everything else fails, then I would also consider maybe putting a endoscope separately and trying to look in and getting a better view.
Angled scope with.
Yes,
Okay.
yes.
Okay, Dr. Amitabh, anything would you like to add on to this?
First of all, I think just changing the scope as Gautam said. But before that, putting pressure on the cricoid, which we normally do, just below the cricoid at the right level, and also waiting for some time for the larynx to relax completely and eventually drop. So these are the two things that I would, and I would also negotiate the scope forward and backward a little bit, because sometimes that does the trick. That's with the scope. And with regard to the position, I would probably, if all those maneuvers that I have mentioned does not help, then I would probably add a little bit of flexion to the head, which is also been referred to as flexion position. And sometimes it's a mistake as a beginner we do, that we try to extend too much, and then we are not going to look at the anterior part more. So if we flex a little bit, that may be helpful. In addition to what Gautam has already mentioned, strapping the neck and negotiating up and down, changing the position to a little bit of flexion, and praying that the larynx would drop after it's completely relaxed.
You mentioned changing the scope, and so did Gautam. So any tips as to, for our colleagues, what scope? Can you mention the scopes? What do you know?
I see commonly we use either Klein-Sisser scope or a Dido scope.
Okay.
And a scope which has a wider diameter, yet not very wide at the apex or at the tip. And Dido is one of the best scopes for that when you have a difficult exposure, which has slight anterior beak, but not too much.
Okay. Dr. Handa, anything besides what has already been mentioned, anything new you would want to add, please?
Yeah, so in this particular case, as we see, your laryngoscope is not is refusing to go in, and the arytenoids, there is a lot of the scope, so definitely it's a much bigger size scope. So we have to shift to a smaller size scope. Apart from whatever all they have mentioned, which is very, very relevant, with only one point, the pressure should be on the cricoid, not the thyroid. If you want the exposure to be better, you can put in a band around the neck. Lastly, some cases I have used a fiber optic also. Even with a video laryngoscope with angulation of 10 degrees or 15 degrees, sometimes you are not able to reach. So you take help of a flexible scope, you attach a camera, put a scope, get a view, and you may use your MRS instruments, especially the right angled ones, in an odd case to help you out with the excision.
Okay. I actually prefer putting pressure on the cricothyroid membrane because I feel it's more giving, and I'm scared of putting too much pressure on the cartilages. So that is my personal preference. Is there anything which Dr. JK or Dr. Rakesh would like to add in addition to all the points which have been mentioned?
Yeah, I think one of the important things is to anticipate these problems. And so you should be, first of all, prepared to face such a thing before surgery, and discovering this in surgery is really frustrating. So you should have a bit of idea that this is going to be a difficult time, and have the right instruments standby. I faced a couple of these tough situations, and one of the things which we did have at hand, of course, other than the nasal endoscopes, etc., was the distending laryngoscope. So though it was bulky to begin with, but the way you twist it, it does open up in a way, like a way, so that it pushes anteriorly, and we could get our job done. This was especially in the case of a post-RT neck. Otherwise, yeah, it's a difficult thing which everyone faces once in a while. Many times it's better to step back, relax, reintroduce the scope with the correct angulation, and more often than not, we manage to get the right exposure.
Okay, so I think patience, smaller size scope, waiting for the GA to act and laryngeal drop. Dr. Jayakumar, anything in addition?
No, I think everything is told here. I actually will also wait for some time, and actually I will mobilize the jaw manually, so that area become a little more flexible. And I actually flex the head and flex the neck. And sometimes I even put 2 layers of sheet under the head, so that actually it becomes flexed. Sometimes it's almost touching the chin, touching the chest like that.
Rest of the patient. That I think that's what Amitabh also mentioned, the flexion. So great tips over there. And then sometimes you have this situation, one is a dentulous, which is really easier to handle. But when you have that one tooth or those two teeth, or those plates, which are, not the dentures, but the plates, especially the one or two teeth, how do you handle it? It can be very frustrating with the scope slipping on one side of the angle of the mouth, and they're trying to save those one or two teeth. So besides, also, do you take a consent from every patient that we may knock your teeth out when we're doing this procedure? So, whoever would like to go in first, please.
I go in at an angle with the first picture. I usually put the scope not in a midline, but in a little angle on the side, so that I reach the larynx, but the scope is not exactly in the midline to
Okay.
avoid injuring the teeth. And another problem with teeth is nowadays.
Hello?
I think
I couldn't
we
hear
have
that. Sorry.
lost Gautam.
Yeah, Gautam. So can I add something in the first
Yeah.
picture? You have one teeth. So in this situation, I will never put a tooth guard, silicone tooth guard. I will just use a gauge piece and come from one side. Because
Okay.
if you put the tooth guard, it will be unequal pressure on one teeth and very likely to dislodge that. And rest of the jaw is dentulous, so you can just manage with the scope. Secondly, when there is gap between, there are some teeth missing, but there is gap, then best is to put the scope through that gap, and it helps you out. Consent is to be taken not just by the anesthetist, but by the surgeon also, because after all, it is you the ownership of the patient lies on. All responsibility is yours. So you have to tell him. And today, a lot of people have those on tooth implants, dental caps, and all. So there again, it's a very real danger. These patients have spent a lot of money on those implants, and if you dislodge the cap or even break the implant, it becomes a serious issue unless they've been primed for that before.
Some people even have little diamonds in their teeth now.
Yeah, and those diamonds are very precious. I had a young girl where she told me, "Doctor, do anything, but don't dislodge this diamond of mine." So
Any other
Just
points?
one small tip, is that for the first case, again, I would agree with all of them that I'll go from the side. But when you go from the side, the laryngoscope, when you fix it on the chest or suspension in whatever system, it's very wobbly.
Yes.
What we tend to do is we put some onto the thing and then tie it with the table, so
like
that
graphene rods?
Yeah.
Like the graphene rods?
Like the graphene rod. That's right. So that actually, in spite of going from the side, it fixes the laryngo suspension system better. I think that is one tip that I would say.
Nice tip. Yes. Anything?
Newport,
yeah.
Something that we do is, so we ran out of the Silastic tooth guards once, and I ran and got some Aquaplast. I don't know if you use Aquaplast for like nasal rhinoplasties and things like
for
that.
these splints.
Yeah, and so I never used it was so good that I never use Silastic tooth guards anymore. Every patient gets a custom tooth guard in the waiting area, and it's you fold it over. It's a double thickness so that you don't get any holes. It fits. It doesn't flop around because it's actually formed to their teeth, and it works great for everyone. But for the people with like one tooth, now you've actually casted that tooth in place. Right. And so it works really good for these partially edentulous people too. And even with people who are completely edentulous, you actually you put the Aquaplast on the gums and they'll get a little pattern there, but they won't get the same bruise that they used to get when we would just put gauze. So I use Aquaplast tooth guard for everybody. And it's a lower profile also. So in terms of hard, difficult exposure, that's something else that might give you a little extra millimeter or two.
Space. Lovely. Perfect. So, of course, what we've started doing is that when this problem begins with the anesthetist, actually, even when they have to intubate. So he makes this little bit of a roll so that he doesn't damage that one tooth or two teeth. And then what we do is we take the gauze and actually fill up all the missing spaces with the gauze so that we've made it all at the same level. Having done that, then we put the Silastic implant because everything is at the same level. And then if you need to even put the stainless steel implant, the dental implant, you can put it over. So that's what we've been doing, and it's been working well for us. Let's go to that.
One more thing, Nupur,
Yes,
just
Please, yes.
If there is a real trouble, I will also invite the dental surgeon to be in the theater. In case, you cannot take it, you actually take it out and re-implant it.
At the same setting after
at the
the
same setting. They will do that.
They'll do that. Yes. Great. That's good. So we can
One
take.
thing also which we do, especially the 1-tooth situation and all, if you like to dislodge, I'm sure most of you will be doing it. We tie it and just leave a thread out. So in case it just goes away, so we have a way to get it
Patient
back.
has not swallowed or aspirated it.
Yeah.
Correct. Yes. Great. All wonderful points. And then we haven't even got the scope in, and we can have so many issues, like very occasionally, but you do come across that very floppy epiglottis, and whatever you do, however you position the scope, it's just flopping there. So I'd like to start with JK this time, please, as to what you would do, please.
Yeah, I resort two things. First option is actually I will go with, I always use the Canterbury scope. That's a pointed scope. I actually go beyond the epiglottis. I actually separate the epiglottis from the posterior pharyngeal wall. Try to go as deep as possible. Then fix the scope there, and then gradually, millimeter by millimeter, gradually withdraw till you know that now another millimeter the epiglottis will collapse, and then by giving manual compression you can do that. Second is that sometimes if I find it really difficult, I actually take a suture through the epiglottis and pull it, use it as a traction towards the anterior part, towards the lower lip, central part of the lower lip, and then put the scope.
I have done the same thing once, that suture. I think it really helps.
Yeah, that's what we have in the image here. The suture is really wonderful. You take it in the epiglottis and keep it out in the midline, and it just makes life so much simpler. Not very difficult to do at all. Is there any other trick? Dr. Pittman, any trick? Dr. Handa, anything else you would like to add?
I just use I go from outside the laryngoscope with an alligator and just grab the tip of the epiglottis and lift it up. And then slowly slip the laryngoscope underneath. And once I have the laryngoscope in place, then I kind of wiggle and just let go of the epiglottis. And so it does the same thing as the suture. I've never thought about this suture thing, but I think that's a great idea for the ones that are just really impossible. Yeah, so thanks for that.
Once in a while, a distending scope is helpful. If you use a distally distending scope and your epiglottis is loose, you can hold on to the epiglottis with the distal distending scope. There are Steiner scopes which are more used for early cancer resections. But I have used this once in a while for this sort of a situation.
The Virda distending laryngoscope.
Yeah.
Okay, all right. Okay, great. And then the nightmare of trismus, or let's say you have a patient like I had. This is a real patient, politician, smoker, 4 stents, followed by a bypass, followed by 1 more stent, pacemaker. It wasn't even a pacemaker. It was something which controls the atrial fibrillations. When they set into motion, it just kicks in. Dual blood thinners, uncontrolled diabetes, COPD, and hypertension. And this guy, I mean, that was his image. I said, 99% it's a polyp. Let's just leave it. And he wanted the surgery. So that's one situation, GA nightmare, or you've got trismus. So, how do you sort of tell me, each one of you, how do you handle your office procedures, or what do you do, kind of thing? If I can start, with Dr. Jayakumar.
Yeah, but I will still do it only in the theater. Even with the flexible scope, I will do only it in the theater, not in the outpatient, because he has got a lot of problems, all these things, So
I'm so happy because that's exactly what I did in the theater. So good, yes.
Yeah. Then with the flexible channel scope, you can take with the cold instrument, or if you can hold a fiber laser, either the carbon dioxide and I would or the any fiber laser should be fine, provided you control you select the correct power. Then you try to take it out.
But only thing, if we're using a lasers, we want to first get at least, his main issue is malignancy. So we want to have enough material for the biopsy.
Yeah, if it look like it is more pedungulated, it might actually come out it is only a still picture, so probably it should actually come out really.
I had hoped.
Yeah.
Well, I mean, I would say this is a post-op. We got I would say 85% out, and his voice is great. But so yeah, that's a great option to take these really dangerous GA cases, I suppose, as Dr. Jayakumar said. Take them in the office. Everything is more controlled. In India, I don't think we have so much of a difficulty insurance-wise in convincing, the insurance company that we're doing an office procedure in the OR. And that also works for the patients with trismus, of course, where you just can't open their mouth. So unless, if someone would like to add something on before we go on to the next scenario.
Any thoughts on the dual blood thinners?
Sorry?
Any thoughts on dual blood thinners? Usually we're okay with one. We don't
We're
always
okay
allow.
with the EcoSprint. We stop the clopidogrel, because that becomes a bit of an issue. So EcoSprint, very often we are operating with, but I've had a situation where a patient was on dual blood thinners before injection, laryngoplasty, and I wasn't typically stopping blood thinners, and I ran into so much trouble with this gentleman where we had to admit him into ICU. The injection laryngoplasty went off really well, but he, within 3 hours, was coughing out blood. We had to admit him into ICU, and we had him here for 5 days. I've really learned my lesson, and so everyone now gets fitness and anesthesia fitness even before I do an injection laryngoplasty in office, and we try to stop the blood thinners, especially the clopidogrel bit of it. Has anyone else faced a problem with bleeding after injection laryngoplasty if they had not stopped the blood thinner, or is everyone stopping the blood thinners?
We are stopping. Just
Stopping.
take it as a GA procedure.
Right. Yeah.
No, all these patients are better than under a MAC, which is local but monitored. So a pre-anesthesia checkup is done for all these patients.
Good. Okay, perfect. So we have this very difficult case who's come from Kenya, and she's been coming to India 2-3 times. I just give you an idea. She has a very hoarse, strained, continuously strained voice, which I have diagnosed as muscle tension. But she has been seen earlier by a doctor in India and was given a filler, Restylane, bilaterally, which didn't help her. And then in her second visit to India, she was given botulinum toxin. So I imagine with a SD diagnosis, which made the voice breathy, which again didn't help her. And this is her third visit to India when this is what her voice was like. And this is her MPT, the E, very soft. Now, when we make her do an inspiratory phonation with my therapist, she does really well in terms of volume. But she's not able to replicate this into real life. And she has the pain, which has settled with the laryngeal, circumlaryngeal massage, but the voice is just not improving. And we, what would y'all do in this situation where the voice is just, so we thought it's been such a long time. So we even gave her a little bit of neuromuscular electrical stimulation to just try to break the cycle. How would you sort of handle this, Dr. Jayakumar?
What was the endoscopy picture, Nobur?
So there were no spasms seen, but there was a complete ventricular hyperreduction happening.
Okay. So the vocal cords were essentially normal, but the ventricular bands were hyperreducing. Is that right?
Yes, correct.
Yeah. Even in the neck, you can see that the sternocleidomastoid, actually, there is a lot of bulging of the lateral part of the larynx. The sternocleidomastoid was bulging out. The root was bulging. So she's actually putting lots and lots of efforts on phonation. So that's she's using ventricular band voice. So most probably primary, because we have seen nothing really wrong with the vocal cord. So she probably developed a habit. And if it is quite longer, then the therapy may not work, but it is still worth trying a voice therapy session, with all those things for a ventricular band, like the tongue thrust therapy, thyroid massage, and even the inhalation phonation. If they all work fine, great. If it doesn't work, then actually I will actually go for, I can even give one more trial of Botox into the thyroid muscle. That I occasionally do, even though there are not enough studies for that. And if it still doesn't work, I will actually go for an endoscopic partial excision of the ventricular band bilaterally, keeping
Okay.
the anterior third intact.
We did Botox her, which kind of got her into her breathy phase. My question also specifically is, before doing the surgery and the, excising the false vocal folds, would you inject in this case a lot of Botox into the false vocal folds? Do you think that may help? And Michael, do jump in whenever with your opinion.
I think she has a functional dysphonia. I mean, we haven't seen this show, but to me, this is functional and it should break with voice therapy because she can phonate, right? And so I don't think it's an organic etiology. But I do think I definitely inject these patients in the false vocal folds. I've never removed them, but you can really make some significant change by putting in, usually start 5 units in each false vocal fold submucosally, and that should open it up. I do find for patients like this who actually have an upper motor neuron injury, and so they can barely get any air out, that will sometimes, maybe half the time, that'll help relax the supraglottic sphincteric closure that you see, and then they can phonate a little bit better.
Yeah, Amita, please.
So,
Yeah, I just want to share my thoughts here. I would also agree with what Dr. Jayakumar and Dr. Michael said, but I think the principle or the philosophy behind the resection that we are talking is to facilitate voice therapy properly. Because the voice therapy cannot be initiated and she cannot practice because of the ventricular bands are coming anyway. So if we do that resection when everything is failed, essentially it's not the aim of the surgery to, but actually to initiate voice therapy in a proper way. And that's how I would look at it. Yes, I would consider resection, partial resection of the vocal ventricular band.
Okay. All right.
Now,
Yes,
can I add in something? Yeah. So initial approach will be voice therapy only because there is a very significant muscle tension dysphonia. Still not then Botox again into the false cords. And lastly, we have done laser resection of false cord, partial laser resection in couple of patients. It is for facilitating voice therapy, but also where the bulk is too much and it is impeding the two cords coming in view. The results were in fact better than what we had anticipated. And though we say everything can be turned back by voice therapy, but I don't think in this case, unless you do a significant resection, you will be able to get her voice to acceptable level.
She's had it for about 7 years, so it's just got so set. Okay, so I think there's great suggestions by everybody. And sorry about that. Moving on, again, real case, sulcus in a singer. Now, we know sulcus is the most challenging benign phonotraumatic lesion. We have it in a singer. This is a male. He's about 60 years old, very famous singer, has his own singing school also. And since about 3 years has been coming to me with the fact, and we can see the sulcus on the right side. And in fact, he has a thin sulcus even on the left. He says the mucus sort of fills and gets stuck in his vocal fold. One can imagine the mucus getting stuck in the sulcus. And he says he just, he can't reach the notes he could earlier. Of course, now we have to also keep in mind that he's aging, but he's just not comfortable. Though he is performing, he hasn't stopped performing. He's just not comfortable and keeps coming back repeatedly that, please help me. What would you do in this kind of a scenario? And I'd like to start with Rakesh, please.
Yeah, no. So I'm with a professional singing voice. I think making an organic diagnosis upfront may not be the right choice here, because just addressing it might just aggravate it, and I would not tend to immediately go in and try to do a lot of other things before even touching this sulcus, because the sulcus may have not been really the cause, and it just may have been there incidentally. So that would be my approach, and especially in a 60-year-old, there'll be other things, and I really don't think sulcus should be addressed upfront as such.
So you're saying you wouldn't do surgery on this? Is that correct?
Yes. I would like just examine it and just leave it for a time being, and try to just follow it up rather than just look for anything coexisting, maybe some small reflux or something of inflammation of this nature, give good hydration, but really not attribute all the things to sulcus.
Okay. Do we have Gautam with us? Okay. So,
Yes, yes, yeah.
yeah, Gautam, do you agree with Dr. Rakesh?
Yes, I do agree with Dr. Rakesh. I would also be hesitant to be very aggressive. Yes, PPIs and maybe a little of voice therapy uh, because we do not know since how long the sulcus has been there, because since we are examining him only during his problems now.
It's 3
So I'll
years
be-
now. This is in
Yes.
2021. So this 3 years, he keeps coming back. He says, help me. So what do we do? Just give him PPIs, therapy? Dr. Jayakumar?
Three aspects. Say, as Rakesh told, I don't think that sulcus itself is causing, because he's 60. Then as you told that the age also must be playing a role. And assuming that it is a sulcus, it is a problem. But you also have to think that, you know, he's a celebrity singer. Already his voice is well known. So any attempt at that sulcus actually is going to change his voice. So I'm not going to touch that sulcus part anyway at the age of 60 years. No way. I will treat definitely conservatively, and I will also tell him that, you know, the age is, there will be change, you know, there will be some change with the pitch, and also we have to adjust something like your Shruti may have to be changed. You need some kind of pitch training. And if at all there is a phonatory gap, I won't mind doing an injection laryngoplasty to just close off the gap if the gap is there. Other than that, I won't touch the medial margin of the vocal cords.
And if we change this to 24 years, does that change anything for you?
Yeah, then if it is a 24-year-old patient, and if we say that, then that symptom has to be really looked at it on, and we have to do a flexible laryngoscopy when he's singing, and then we have to see what is actually flexible scopy with the stroboscopy. So we have to see what exactly is happening. Is he using it the normal way? What is his pitch range? Obviously, a sulcus patient will have a Shruti much higher than that because the higher pitch, and what are his range. So that require a detailed investigation, no, regarding his vocal cord function and also his workload, and then you'll have to decide upon. For
And
this,
if you did decide intervention, would it be again injection as a first? If there was a phonatory gap, and would you go with injection or something else?
yeah, that depends upon the stroboscopy. Now, how is the mucosal vibration there? If the vibration is good enough, then because I would love to, in a singer, I would really like not to tamper with the medial margin as far as possible, because that you are into trouble, right? If only after every option is exhausted, I will actually go for that. If it seems that he has reasonably good mucosal wave, right? Anteriorly, there is a small phonatory. Yeah, he has got a gap there. So I think I will go for a paraglottic injection and close off that gap, and then train him, and then treat the reflex, and teach him the how he should actually readjust his pitch, his Shruti, and then go ahead.
So can I just add this that interesting aspect you mentioned about being a young singer? So I've had a case where you had a radio DJ actually, and she had a similar problem. But what I did try that time was injection with saline. So I said, look, I'm just going to try something, and if it'll work. She had a very husky, hoarse voice, and we said if it works and this thing is improved, you let me know. Then we'll go for something more definitive. And you'll be surprised. The person did feel better, but he said, no, I'm happy with my original voice because that's what is selling. So that was another thing where I did try injecting once with saline. With
We did a test saline injection.
Like a test.
Patient. Okay, interesting. Good. So that was a sulcus we picked up on stroboscopy, but sometimes, you go and you're doing surgery for this patient who's got a cyst on the right vocal fold, and you find a sulcus, incomplete mucosal bridge. So question to Dr. Amitabh is that, do you do anything about the incomplete mucosal bridge or the sulcus, or you leave it alone?
I would deal with the primary pathology for which the patient has been taken, and I would leave the mucosal bridge as such because I think with this mucosal bridge, this person must have been phonating for years together. And only when the cyst has come, it's the chicken and egg situation. Though we do not know which one was earlier, but it is expected that the cyst came later. So I will counsel him and him or her, and then I will tell him I'll take the cyst first, and we'll have to see how the results are, because the cyst must have come later, and that would have the primary cause of his problem. I mean, that's how I look at it.
Okay. What is actually the consensus about mucosal bridges? I would like everyone's opinion. You know, you have taken up a patient for polyp. These are two different patients, and you know, you find a mucosal bridge. On the left-hand side of the screen, you see a thin mucosal bridge. On the right-hand side, you see this really fat mucosal bridge. But you've taken the patient up for polyp surgery. So do we have any consensus on what? Let's say we knew beforehand there is a mucosal bridge, like you saw it on stroboscopy, as you see here. Do we have any idea what we should do for mucosal bridges? And I'd like everyone's opinion because there is no gold standard for mucosal bridge management. So let's start with Dr. Handa, please.
See, in this situation where there is a coexisting mucosal bridge, we should handle it, we should take it out. But suppose I do a stroboscopy and just find an isolated mucosal bridge, incidental finding, voice is not very bad, then I will be very circumspect in just attempting surgery for the mucosal bridge. But here,
of course,
the more common situation is you have a sulcus, you are handling a sulcus, and there is associated mucosal bridge. So there, when you do the sulcus, you handle the mucosal bridge out.
So by handle, you're saying excise.
Excise.
But what I have shown here is like a really thick mucosal bridge. This is the image of the same patient where the polyp was removed. And this thick mucosal bridge, you can see it very clearly, is more than half the width of the vocal fold. So the vocal fold will get appreciably thinner.
No, I understand that. But as I make it out, even to excise the polyp, you will have to give if you're doing with laser, a laser cut, where you are lifting it with the instrument. I don't think it looks to be a broad-based polyp. And there is some telangiectasis vessels or hemorrhages. So you'll have to anyway handle these. So in this particular situation,
we remove the polyp. This is a post-op. We remove the polyp. He's got great mucosal bridges, but this is it's a very rare to see a mucosal bridge in stroboscopy. We actually see it here, and we see the thickness of the mucosal bridge. And the reason I have this image always is just to appreciate how thick that mucosal bridge is and how thin the vocal fold would be had we excised it. So, you know, I'm asking because there are no gold standards. You have thin mucosal bridges, you have thick mucosal bridges, you have incomplete mucosal bridges. Yes, Amitabh, please.
No, I'm just going to
Yes,
repeat
Dr.
what I
Amitabh.
said. If this kind of a mucosal bridge is there, and if I resect it, as you rightly said, what are we going to do with the reduction of the bulk of the vocal fold? Then you have to probably go and inject again. Rather than that, my philosophy is that if I think the cyst or the polyp came later and the mucosal bridge was there before, why not resect the polyp and see how the phonation, how the volume, how the bulk, everything works. We have to counsel the patient that yes, there may be a situation where we may have to go. This is my, my ideal idea of doing not resecting this, unless I have a 1 millimeter bridge.
Yeah, the thin mucosal bridges, I think probably doesn't matter. Dr. Rakesh, please do come in.
Yeah, so I'm of that old school opinion maybe that mucosal bridges are more like congenital things. So obviously the hoarseness which is happening or the dysphonia which is happening is not really attributed to them. Yeah, they may be contributing to in some ways secondarily. So like Dr. Amitabh said, address the primary lesion, and this being if it is a congenital lesion, probably leave it alone for the time being, and you can always stage it to do something later. So that would be my line of thought.
Sure. Dr. Pittman, do you have any different thoughts or anything you'd like to share with us?
I would be more firm about never removing these. I mean, I think that this is congenital tissue. Sometimes it's the only vibrating tissue in the vocal fold. And part of the reason I said is because I have removed these. I've removed these and then implanted fat in the scar. I've removed these and put in temporalis fascia, thinking that I was going to bulk it up and get better vibration. And nothing is as good as leaving it. And sometimes you just have to tell the patient, you were born with an abnormal vocal fold. You're never going to have a perfect voice. We'll get it as good as possible. But I think if we really aggressively try and make the voice better, you're just going to make it worse. So I would never remove a mucosal bridge of any kind.
Okay. We'll move on to the next situation, which in India, at least, we face very often, which is sometimes you have the patients with thin keratosis, sometimes with thick keratosis. Keratosis, of course, is a histopathological diagnosis. And so I've just shown the histopathology and, how it appeared during surgery. But when the patient comes into your clinic, you're thinking, okay, it's leukoplakia, but you're thinking it's thick keratosis. How do you counsel them? How do you decide to tell them that how often will it come back and how often will you operate? How do you handle these patients is my question, because they're a very challenging group. It comes very often as just benign, but then you have the dots coming back and the thin leukoplakia coming back. So is Dr. Gautam with us by any chance? I'm just wondering. Yes, Gautam.
I'm around, yeah.
Yes. So
Yes,
how do you
before-
guide these patients? Yes.
I would definitely counsel the patient about the possibility of recurrence, because that is the most vexing sort of problem that we face. And at the same time, I would also be telling him that you will not be probably after resection getting the original voice that you have, because we do not know how much resection is to be done to get the whole keratosis out. And then, of course, I would prefer to keep this type of patients on follow-up regularly. I would usually give them a protocol of 3 months follow-up. And then if the recurrence is not there, then we go back to 6 months for the next year, then 1 yearly further.
And let's say, Dr. Pittman, a few dots of leukoplakia do come back. How do you decide whether to reoperate or not? Michael, your audio is mute, I think.
So white lesions are really difficult. And not all white lesions are created equal. And to me, this looks more like a verrucous carcinoma than your typical leukoplakia. This one, it's big, it's hairy, it's got those very long fronds. And so I would be more likely to take this person to the operating room and treat it like a verrucous carcinoma versus a run-of-the-mill leukoplakia, which maybe biopsy has a mild, moderate, severe dysplasia. And so I think those are two different entities. In terms of the typical leukoplakia patient, I tell them it's going to come back, and then you're lucky if it doesn't. We did look at 40 of these patients that we've taken care of, and 70% of them never went to the operating room. So we'll biopsy them in the office and then laser them as needed. The good question is, when do you laser? I always do one biopsy up front and see where we're starting with, right? And then when do you laser again? And we found that if you laser someone and there's not much change at all, or if you laser them and they have a significant recurrence within 6 months, that there's about a 50% chance that they're high grade or carcinoma in situ. So those are the kind of the warning signs. But there are lots of white lesions that if they're small, that I just watch, and they'll come first every 3 months, then every 6 months, and if they're not changing, I'll just watch them, especially if I've lasered them once or twice and they kind of always come back to that small little lesion. So there is no gold standard like you were asking before. It's sort of a sense, but I do think you need to watch them in perpetuity so that if they ever start changing, you're there to make that, to operate on them before they become like a real significant invasive cancer.
So the first initial histopathology almost kind of guides you, and the office procedures here are a real boon because you can take care of the small little patches. Would anyone like to add anything on with this scenario?
I think if they're generally, if you're dealing with a male and he's got some risk factor, it's very important to counsel him. I think keratosis is a lot about counseling and telling him that, look, this needs a relook again and again, and it's likely to come back. And in a male, I would be very cautious. having said that, many times we are missing a malignancy. So I think that's something which we need to always keep in mind. And I think that's what our main philosophy would be.
So only one point, the office procedures is fine, but most of these, the actual malignancy lies deeper. So even if as office procedure, if you just pluck the whiter portion, and you may miss the diagnosis. If it is, we are talking of verrucous carcinoma, the superficial tissues will not give you the diagnosis. So we may approach telling the patient, we are taking you to table. If we have, allow us to, if there is a possibility, we may excise it totally, not this lesion. This is anterior commissure, this is different. But in certain lesions which are mid-membranous, but if we feel it is going towards malignancy, we'll just come out with a biopsy. Because as office procedure, if you miss the diagnosis and you just keep them on follow-up, I have seen 1 or 2 patients where they were stage 1 and deeper malignancy was missed, and by the time we diagnosed, it was already stage 3, the cord had become fixed.
Sure, point taken. For a clarification here, the histopathology belongs to the patient. We excised it completely. It was benign. However ugly, hairy looking this thing looks, it was benign. The tricky bit begins that, okay, it was benign, but it comes back, and is it staying benign? So, it's something we all face, So should it be, like how with papillomas, we do a biopsy every 3rd surgery. Should we, maybe if you're doing office laser, then at least every 3rd time, try and get a biopsy, something like that, so that we don't miss the scenario which Dr. Handa mentioned, that, it's getting invasive. I mean, it's difficult to have gold standards, and it's, one tries to minimize the surgeries for the patient. It's tricky. It's really this, I think, one of the most tricky situations is keratosis or the white patches, if you may. And along the same lines, you've done a cordectomy, you've done a type 2 cordectomy, and then you're doing the surveillance. Patient's not been radiated, of course, every time margins. Now, this gentleman has been operated 7 times in Mumbai by various surgeons, very well. And he keeps recurring with small lesions. And then he had this quiet phase for 4 years where he was really great. And the surgeries have been done on both the vocal folds, but it started with the right vocal fold. After 3 to 4 years of this quiet phase, he suddenly comes to me with acute hoarseness, change in voice since 2 weeks or 3 weeks. And this is the picture he's got. So we have... He says nobody has given him steroids in inhalation or oral, but this is the picture. So, Dr. Jayakumar, if we have you, JK, how would you handle this? Acute hoarseness, 2 weeks. This is a picture in a patient with malignancy of the right vocal fold and then the left vocal fold, and then everything healed for 4 years.
So the previous biopsy report was proven malignancy, no?
He's been operated 7 times. He's had 7 times. He's had invasive squamous cell, and he kind of from one vocal fold to the other, and every time laser cordectomies are being done.
Okay.
By many surgeons, including me. The last one was me, and then he came after 4 years with this picture.
Yeah, and in between 4 years, he was perfectly okay. And now he has got a hoarseness for 2 weeks duration.
Yes.
So it is an acute onset. I will not actually jump to the surgery straight away, because there are conditions like ulcerative laryngitis, which can actually follow an upper respiratory infection and a violent bout of coughing. So I will actually try to keep him under strict observation. I'm not going to let him go for a month or so, but keep him on a regular follow-up for a week, when next 2 weeks, and treat conservatively. If he has got dry cough, has got irritating cough, I will control it. I will control the acidity and treat symptomatically, then review.
Okay.
With NBI too, you can use the NBI.
Would you want to add any antifungals in here at all?
Is there any history of immunosuppression in this patient?
Actually not. No.
I won't.
Okay. Anyone else?
I Hello.
Yeah, Amita, and then Dr. Handa, yes.
I would definitely try a course of oral antifungal.
Okay.
There's no harm in trying. They are not very toxic drugs.
Okay.
And also that if it does not settle, then in a country like India, though it's a short history, we should still think about investigating for tuberculosis in a
Okay.
patient who had
All right.
multiple surgeries and all that.
Okay. Yeah, with a monocorditis kind of picture coming up.
Country
Okay.
like India.
Right, right. Yeah, did Dr. Handa or did Dr.
Yeah. So I will just add in. See, this is proven malignancy. This sort of a picture we cannot ignore it. 1 week of antifungal or steroid is fine, maybe 2 weeks also. But if this lesion persists, he merits a biopsy again. Maybe not straight away podectomy, just do biopsy even as office-based procedure or under GA. And then he, based on the biopsy, needs further treatment. Where you have resected 7 times, I think, and it turns out to be malignant on biopsy, it is high time for us to send him to the radiation oncologist. Because 7 resections are too many. We have done up till 4, 5, but 7 is probably too much. Again, with the CT and MRI picture.
Yeah, but Dr. Handa, the problem then comes back. The same thing you raise. Now, if you are doing an biopsy, the negative doesn't mean anything. It can be positive somewhere else. So if you
the sensitivity, I understand what you're saying. The sensitivity of biopsy in this sort of a lesion will be as high as more than 95%. But in verrucous lesions, what we saw as office-based procedures, it will be much lower because there classically the whitish lesions are superficial and malignancy is down. Here it looks to be, if it is malignant, it's sort of a infiltrative one caudal lesion. So even office-based procedures, if properly taken, will pick this up.
But
yeah, I think
it is negative. It is still problematic, So I don't think I will. If it is persisting, I will go for excision rather than a biopsy and then going.
But Dr. Jayakumar, question will be excision as what? Will you do a type 3 cordectomy? Will you do a type 1 cordectomy? Because we do not know the lateral extent. Or will you go after an MRI? Because if you say excision, because 7 times, it is unlikely to be just subepithelial that we can just get away with a type 2 cordectomy.
Dr. Handa, let's get a clarification here. 7 surgeries have been done, counting right and left focal fold over about 10 to 15 years. Every time he has phases of 1 year totally healed and then the other vocal fold develops. But he has never had a type 3 cordectomy. He's either had every time a type 1 and once he's had a type 2 cordectomy. Also, I think just because 7 surgeries are done, we should push the patient to radiation therapy. I don't think I agree with that because the whole beauty of surgery is you can do it 100 times as long as the guy has got a good voice and he wants this. He doesn't want radiation, and radiation is something almost I see as a last option very often. So, I mean, I don't think we need to push a person to radiation just because it's a 7 surgery, because we do 100 surgeries for papilloma. I mean, we do many surgeries, and the whole beauty or advantage of laser surgery is that you can do it as often as you want, right?
Dr. Nupur, it is very beautiful, but only thing is, was it proven squamous cell carcinoma, or was it something like dysplasia or some proven?
Is that carcinoma in situ? Every time the pathology.
No, carcinoma in situ is different. I'm sorry then. I got you wrong. If it is carcinoma in situ, it is different. Then your approach, I will 100% agree. But if it is proven
carcinoma in situ once, he's had invasive squamous cell once, then again he had carcinoma situ, then he had moderate dysplasia. Every time it's a little different. So what we did, and add on to like and the cough reflux, we give Zocon, like Dr. Amitabh said, we give Zocon 200 milligrams. So a lot of surface hydration nowadays in these patients, where we ask them to do sterile water or saline nebulization, no steam. And so we give them systemic hydration, of course, but we give them surface. It's very interesting because a lot of patients, and this was, within 2 weeks, and I was like, look, if it doesn't settle in another 2 weeks, we're going in, taking out that whole carpet, but the NBI would not show an IPCL. And like all of you all rightly said, NBI has a huge role to play over here. And very beautifully, within a month, we gave the antifungals 3 weeks and stopped, but we continued with the sterile nebulization. And within a month, everything is just cleared off. So, I think what I'm trying to share also is that a person's had malignancy 7 times, we've operated, he's had it over 15 years. As long as we have a good follow-up, as you mentioned, one of our colleagues mentioned, good follow-up, you don't want to lose this patient to follow-up. We don't have to. It's fair enough to wait for almost up to 2 months, I think, where early eclotic cancer situations are concerned. And I do want to mention here that I always take out lesions as a carpet, because I totally agree with Dr. Handa and Dr. Jayakumar that targeted biopsies is not a great idea at all. If you're taking the patient in for a biopsy, take the whole carpet out. And here now is a situation, and it's important because as a voice clinic, all of us we get patients first when they are with early lesions. Here we have a patient who actually came from Amitabh, Kolkata, and was, sent by a patient of mine. And so the idea is, if a patient is not improving with your conservative lines, even though you may think it may be a cyst, how long do you wait? Do you do narrowband imaging for your patients? Amitabh.
Sorry, what is the question?
Questions. If a patient is not improving, voice is not improving with whatever treatment you may be giving, how quickly would you want to either take a second opinion or take under anesthesia? And how often do you do narrowband imaging in patients with hoarseness of voice where there is some kind of a vascularity?
We are currently not doing the narrowband. We are doing the spectra when we take the patient to the theater. But
that you've already taken the decision of surgery then.
Yeah.
I'm saying using narrowband or, a pre-surgery decision.
If I have I currently don't have a narrowband in my clinic, but if I have a narrowband, it will be a routine for all these patients. I would not consider that as a separate investigations, because I think all these patients should be, every sitting they should be, seen for this pattern, vascularity pattern.
Because it really sometimes is unfortunate if its patient is going to a doctor for hoarseness, the hoarseness is not improving for 3 months, and we keep giving steroids, PPI, and there's a cyst, but it's not a cyst. This was invasive squamous cell carcinoma. It had gone into paraglottic. It then now needs a concurrent radio chemotherapy. So I think we should give the message, maybe if you don't have the strobe and NBI and the patient is not improving, maybe we as an association or various associations should say in a month, if that's happening, you have to, refer to a center which has these technology, because I think otherwise it's rather unfortunate that we're missing out and we are letting a T1 become, a T2 or a T3.
Absolutely.
I think we had a great discussion with Dr. Pittman regarding what you do, but I specifically put this because neurolaryngology and laryngeal renovation is becoming such a hot topic, and it's changing our practice in a way. So I would like to know from everyone that they have a patient who has 3 years of hoarseness of voice who comes to them for the first time. It's a left vagal schwannoma surgery which was done. Occasionally the patient is aspirating to water with an MPT of 4-5 seconds. This is a gentleman who had come in 2018, and this is the image, and I'd like to have everyone's opinion as to what they will do for the patient. I'm sure everyone will agree that some kind of surgery is required. So if we can start with Dr. Gautam Khan.
How old's the patient, Newport?
This is a gentleman who is pretty young. He was about 28 years old, pretty young. If Gautam's not there, then, let's have Dr. Jayakumar's opinion, please.
Yeah, 28, and obviously I'm sure that he's not a diabetic, no?
No, he's not. He's a fit chap.
So yeah, I think usually I know that there is a cutoff point, something like 2 years, after which the muscle will get atrophied. But I think in larynx, it need not happen always. So I will actually still, since he's a very young patient, there is a very bad tone and bulk of the patient. I will still go a trial with non-selective reinnervation of the case. And at the same time, I will also inject the filler, the hyaluronic acid, then follow him up. I will always tell that there is a possibility if it doesn't work, then of course he will require a static correction surgery with thyroplasty and possibly retinal rotation.
If it doesn't work, you'll first do an NSLR. If it doesn't
NSR with injection at the same time.
Okay. And Amitabh, what would you do?
I think as of today, 2024, I would offer him type 1 with a retinoid reduction, but I would definitely discuss the option of the what Dr. Jayakumar said, non-selective surgery. But and if the patient chooses to do that, then I would currently, just because I am not doing that surgery, I would refer him to somebody who. But with my setup, currently I would still go for a definitive permanent surgery, which is the type 1 with retinal reduction.
AA. Okay, right. Dr. Handa?
See, here I will go for a thyroplasty plus minus retinoid reduction. Decision to do retinoid reduction on table if he agrees to get this done under local anesthesia. Possibly, most probably, he will end up with a retinoid reduction. Now, regarding NSLR, now I have started accepting what Jay Kumar and some parts of you have started saying for last 1 year. And so today, if you ask me this question, is fine, but maybe 6 months, my answer may be in line with what your or Jay Kumar's answer will be today. There is resurgence of interest in this, definitely. But still, I have only one question to ask both of you. In non-selective renervation, you suppose even after 2 years, 1 year, here only problem is you are cutting off the normal nerve. If there is a potential for some regeneration, so how do we address that? So it is a simple surgery. There is nothing. You just get ANSA. You do a anastomosis. But if you can convince me on this, maybe next time I will answer what your expected answer is.
Dr. Jacob,
you are going to lose 3 years. The patient doesn't have voice for 3 years. What are you going to benefit? Nothing is to be there. There is nothing to be lost. Patients with a very bad voice, very breathy voice. There is a hugely overriding normal arytenoid. There is a big phonatory gap in the anterior tooth, and there is a phonatory gap at the vocal process level. So what else you are going to make worse?
No, not worse, Dr. Jakumar. See, nerve regeneration is something which is very unpredictable. How when you put two stumps of nerve together, here also when a nerve is injury, the nerve is injured, the nerve rehealing again is unpredictable. Even if he is not, there is no comeback of function after 1 year, 2 year, 3 year. Maybe there is still a chance. And here we are cutting off the nerve. So that is the only questionable thing in my mind today.
So, Dr. Handa,
the patient will also ask you that question. So,
right. So my answer really is in most of the research papers that I have read, we have seen after maybe even after 1 year of immobile vocal folds, sometimes recovery take place. Usually it's within 6 months. I don't think there is any published paper where after 3 years recovery took place. So I think it's totally justified. Of course, one can do laryngeal EMG and see the potentials that you are getting. To see the negative potentials are always even more accurate than positive potentials. So I think we can totally explain to the patient that they are not in any way worsening their situation. Dr. Pittman, I would really like your opinion on how you would manage this case also.
Yeah, so I would agree. After a year, I think what you have is what you have. And we do a lot of nerve, that's my basic science research is all on nerve regeneration. So, and the truth is I don't bother with the EMG because it confuses me if it's helpful. So if there's not a lot of innervation, some people say you should do the reinnervation, but sometimes I think if there's not a lot of innervation, then there's not a lot of motor end plates to re-innervate, right? So you actually might be better off doing a patient who has more innervation. So I don't know if there's a real answer to that. So this is a case where I would definitely do an answer to recurrent laryngeal re-innervation, especially because of the age. That's really my primary consideration. I don't want to do them you can do them in patients who had thyroids before, but I don't do that. If I did, I'd probably have to do it with one of my head and neck surgeons to try and find the stump. But someone who's 24 and has a vagal injury, I think they'll do wonderfully with this surgery. And it's a pretty, if you look at the literature, the success rate in this patient in particular would be about 98% with the ANSA alone and nothing else, which is honestly, I think, better than doing a laryngoplasty in a patient who has a significantly atrophic vocal fold. So that's how I would handle it.
So of course you all can jump in at me, but what we've been doing for a lot of our patients actually, and a lot of this may come of the fact that I'm not very certain as to whether the ANSA recurrent will take or not. So I just do it all really. I do the ANSA recurrent, I do the thyroplasty and A all in one sitting. I know there are some other surgeons who do this too. We've been doing this and I really feel we should do our comparative study, our own study as to whether this will do better with as compared to the group like for what JK does, where it's ANSA with injection. So this is the patient after surgery, this is 5 to 6 months after surgery. And now we see the arytenoids are symmetrical. We can actually see the vocal folds. So most of our patients have done really well with this combination of ANSA to recurrent with thyroplasty with AA. The implant I make is silastic and I make it about 1 to 2 millimeters anteriorly and 5 millimeters posteriorly because I just don't want to over medialize, and now I have lost that advantage of local anesthesia. So it's just like a little better than what hyaluronic or fat would do, I think, because it's definitely permanent. And the patients have been doing well, but of course, scientifically, I need to compare this with just the non-selective. And then we have that situation of the abductor, severe paresis or paralysis, if you were to say. This is a patient who had actually a stitch lateralization someone had done on her, thinking it's reversible, but as we know with time, it never really is, but the cord stays like a monochorditis. And we are typically doing the Kashima, but so I would want to know, again, because I'll address this to JK because I know he's got the maximum experience in India with the selective laryngeal renovation. So I would like to know how he decides and which group of patients to sort of advise the selective laryngeal or Kashima, or does he explain everything and then leave it to the patient? So JK, tell us a little bit about your experience because you have such a wealth of knowledge in this right now.
Yeah. So I'm so enthusiastic about the non-selective reinnervation. As Michael told, the results are as high as 95, 90%. It is very high. Even our results are similar, but bilateral is altogether a different game, right? So the results are not that great. I will say that. What I have done is that 8 cases. All of them were actually decannulated later. And they had some improvement in the glottic airway at 6 months. But unfortunately, at 12 months, 4 of them, 50% of them went back and had what is known as the delayed synchronesis, requiring some kind of static procedures like Kashima or codopexy. So only 50% had actually improvement at the end of 1 year. But those patients who had the improvement, what I will say that the difference is that not all of them had actually great movement, but some movement, one side more, but adequate glottic space, including the child and adolescent. But what I will say that the voice were perfectly okay. They didn't have the bad voice of Kashima or thing. I will not say that any of my cases had absolutely normal abduction. None of them had full abduction, but they had some abduction on more, I don't know the reason, more on the left side. And so the glottic space is adequate in 4 patients at the end of 12 months, I'm telling, and they all are doing well so far. And they had good voice. So what I will say now, a patient coming, if it's an old patient, means even above the age of 55 or 60, there is no question of I am advising selective reinnervation at all. I will actually go for a static procedures only. I will consider a selective reinnervation only when the patient is young, say, and all my better results are actually less than 30 years of age. So maybe anybody less than 40 years of age and who is actually a voice professional, like a teacher or a professor, somebody like that. Again, I'll take a very, very, very detailed consent. I will tell the alternate possibility also. I will tell that the standard operation will be the something like a static operation, where it is a much quicker operation. The hospital requirement stay is less. The glottic space will become widened, but of course your voice will become husky. It will go down. If there is, so they will ask, is there any other way? Then I will tell her there is a way, but that surgery is not really under, I cannot really guarantee that something will happen. It is worth trial, but it needs lot of hospitalization, at least 2 weeks. You will have problem with the swallowing for 2 to 3 weeks. You will have a tracheostomy if you don't have a tracheostomy, and your expense will be 5 times, 6 times the conventional operation. So that is the standard advice I give to them, and I also show the results I have got. And I will say that this is the, and I will also tell that despite all this surgery, sometimes at the end of 6 months, 1 year, I may have to resort to the static procedure.
Sure. Michael, are you doing the selectives?
I think he may have left.
Yes. Okay.
Yeah.
So really, we struggled a lot with the one selective laryngeal renovation we did in this young boy who was about 10. It almost took us 2 years to sort of have him completely blocked. He has a small tracheoesophageal fistula now, but he was basically a papillary C of the thyroid with metastasis, and the same oncosurgeon and I operate together. But now he's wonderful to hear his voice.
I live in Pandipur slowly. I decided a poem in English. The wind is a notition who whistles fan and loud to a bell, such a gap of rain, rainy cloud. He wonder here, he wonder there.
So it's really a pleasure now to see at the end of 2 years. This kid has got a normal voice and he's really doing well. We've just got this one experience, so not much to go on, but of course it's a joy to finally see him do so well. And maybe we're ending our panel now, and this could be our last slide. We all know that botulinum toxin is what we do for spasmodic dysphonia as a first step. This is a young child with severe spasmodic.
2, 3.
This is an elderly lady with very severe, both are adductor spasmodic. My question really is, what do you do to the non-responders? What I mean by non-responders is, the injection went into the correct place. There was a long breathy period of 2 months with 2.5 mouse units on either vocal fold, and the good voice was just 1 month. And how do you just tackle these so-called non-responders? Amitabh, would you like to take this question?
Well, really a bit of a challenge in these patients. We can do an expansion sort of thyroplasty where you get the vocal folds apart and the spasm goes away, but the voice becomes very breathy. So we've done that in a few cases earlier. We have done a partial resection of the thyroarytenoid muscles, which also does not, the results are good initially, but then they tend to come back again. In theory, I have not done that operation called thyroarytenoid myoneurectomy. That may be one option that I would consider or taking up in the future. But otherwise, this is all my experience what we have.
Okay. What about Rakesh? Are you handling SD patients?
Yeah. So we have had a couple of few non-responders, and we are like there's some people I know who would like to thyroplasty, but I would prefer to go in for a laser-assisted thyroarytenoid myoneurectomy is what it's called, but definitely it's not easy to find the nerve. But definitely we do release the muscle so that the spasm goes. It has some good short-term results. Long-term, I'm not very confident, but then it at least gives a break to these non-responders. Otherwise, Botox being the first way to go.
It can be repeatable though, but then difficult.
JK, what about you?
Yeah, right now I will first choice is always Botox, and if for some reason or the other the Botox is not suitable, I will actually go for surgery. I actually go for the coablator assisted thyroaretinode myoneurectomy. I take around 1/3 to 1/5 of the muscle bilaterally, and 50 to 60% of the case you can actually hook the nerve there out there and then lift the nerve and then cut it. Dominguez Suji has got great result, but he's far more radical than what we are actually doing. He takes around 70% of the muscle, and actually he put the Riles tube for 2-3 weeks. Patient has got severe swallowing problem. So his results are much better. But one problem, I believe that recurrent laryngeal nerve has got an inherent tendency to grow back, whether you cut it or not. So this surgery has got a problem. You are cutting the nerve within the muscle. It will invariably regenerate. There is no doubt about that. Because you are cutting the nerve inside the muscle. So whatever effect this surgery is having is actually due to the removal of the muscle. That is why I believe that Dominguez Suji's results are far better because he's so radical. He takes around 70% of the muscle. So whether you cut the nerve or not is actually not important. It may give immediate result, but the real result is actually for the muscle removal. So I believe that now my choice is that I do the type 2 thyroplasty only for professional voice users having a spasmodic dysphonia, because as of now, that is the only reversible operation. So I keep the reserve the type 2 thyroplasty for only for professional voice users having thyroplasty for spasmodic dysphonia. Otherwise, non-responders, I go for thyroid node myoneurectomy. But I strongly believe that with now my experience in reinnervation and everything going on, I think probably the better result will be what Dr. Chetri has the SLADR, the selective laryngeal denervation, renervation. That should be, because that is theoretically much more sounder. Because you are cutting the nerve, you are actually burying the proximal segment somewhere else, and you are taking answer to that thing. So theoretically, that is stronger surgery. But as James Thomas tells, Dominguez Suji has got terrific result. We cannot actually refute his results. His results are great.
But you do know that Suji's results, he needs 50% of his patients need a second surgery, and 30% of his patients need a third surgery. So that is also...
No, Gora. He told 50, 20 and 5.
I think it is 50%.
No, it is 20 and 5. It is 20 and 5.
20%?
20% two operations.
Second and 5% third.
5% in
I stand corrected. So that's something which is available to the patients. But have you also, there are a lot of papers now about the false vocal fold Botox injection,
yes,
especially for patients who are non-responders. Have any of you been? Because I've started doing this, and it's very interesting because the main problem is the breathy phase is too long, good voice is bad. So if you do false vocal fold injection with the slow trickling of the Botox, the breathy phase actually becomes shorter. So I've just started doing this, but any of you doing it?
No, I don't do.
But this is something interesting for non-responders. Maybe we can consider, because you don't even need EMG done more as an injection laryngoplasty, just inject into the false vocal cord, but double the dose. So there's a good paper out by Blake Simpson about this. And bamboo nodes is something, of course, very common. With bamboo nodes. Of course, you want to look for the primary issue of, maybe some kind of connective tissue disorder, but I've had about 3 patients. Does anyone have experience with bamboo nodes?
I haven't.
No, okay. Anyone at all?
Yeah, I
No,
have one
yeah.
patient, but he didn't have any rheumatoid arthritis.
Okay. One of my patients had Sjogren's, one of them had rheumatoid. Dr. Handa, did you operate on
Yeah,
any?
no, I have seen about 2 or 3 patients. I have not operated any of them because their focus was more on the systemic disease. They had rheumatoid arthritis. So ultimately, they just went for therapy. The voice was not so much of a concern as compared to their systemic disease.
That's the usual way. Most of our bamboo nodes also, when we pick it up, it's what we pick up that becomes the primary concern. But there was one patient who I thought was bilateral cysts because it was not multiple nodes. I operated, it turned out to be something which matched a picture of how bamboo nodes should be. Also during surgery, they were more linear and caseating and not cis. That's the patient who turned out to have Sjogren's. And she is doing reasonably well with her voice, but I feel tiny bamboo nodes are developing again. So that was my only tryst to bamboo nodes. This is actually, I promise you, our last slide. Paradoxical vocal fold motion can be very challenging. We had this lady who, while she's sitting also, she'll have this stridor sound which appears, and then, typically sleeps like a baby, no problem while asleep. So we get these problems occasionally. She's got a very classical stroboscopy of showing the paradoxical vocal fold motion also. As she goes to breathe, there is stridor. So we give Botox and she did much better, but is there any other option? We do respiratory retraining and Botox for our patients. Is there any other option or medication that anyone can suggest for patients?
I think the best treatment is via good trained voice therapist who understands paradoxical vocal fold movement, and the therapy with the breathing, getting the patient in tune with the natural breathing excursions. Because what is happening here is during inspiration, the cords are adducting. So, with a good training and sort of a biofeedback on a speech, on a program, you are able to show most of them do well, though it takes time for them to be to come to tune with what is happening, because this can be something very, very alarming. Suddenly the patient has choking these feelings, and most of them are with the respiratory people diagnosed as asthma, or and they are not diagnosed properly unless a sensitized laryngologist sees and diagnoses.
I think that is a huge challenge trying to get them from the respiratory, because generally they have been labeled with severe asthma, and trying to find them and then diagnose them. I think that's the bigger challenge. And after that, of course, I think what Dr. Handa said, voice therapy being the main thing to help them. I have not reached the level of Botox for these guys yet.
But I just add one thing. I think echoing what Dr. Handa said, the voice therapy, we have to find a good voice therapist. You have to train your voice therapist, because this is a different ball game altogether. And this is another point, is that this is one area where with the so-called biofeedback that we talk about, it really works. So the therapy involves too much of biofeedback, showing them the scopies, and then only they can, many of these patients get better. And as Nupur said, Botox and other things, as she said, other things. So
we actually don't call it even voice therapy. We call it respiratory retraining. We want to focus on the patient, what we are trying to achieve. JK, you have any tip to add to this?
Yeah. I think this paradoxical vocal fold movement, there are other types also. It's just there is a condition known as the inducible laryngeal obstruction. And now I had a recent young lady. She was a doctor in a Malayali, but she's working in UK. Last time the winter was very tough, very harsh in UK, and throughout the 3 months she was having severe inspiratory stridor. And when she sleeps well. It was typical paradoxical vocal fold movement. So the inducible laryngeal obstruction is there. So I don't think everybody is going to respond to the voice therapy. Botox is definitely the treatment to knock off the temporary problem. And I think Sanjay's treatment may offer thing, that auditory feedback may be there rather than so in addition to what Amitabh told, the biofeedback, the auditory feedback might be an option. We don't know about it, but I think I will still give Botox because symptoms are very frightening to the patient and the bystanders. It is very, very frightening. We know that they are not going to die. They will never die. They know they are not going to crash. That we know that. But it's very, 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 very scary.
Yeah, sometimes the Botox just helps to break the cycle. Like in functional also, sometimes you need something to break a cycle. So I think this has been an amazing panel. I'm going to stop my screen share right now and just check whether we have any questions in the chat box. So we have Dr. Michael Pittman saying thanks, and Dr. Dr. Palyanpan from Tiruchirappalli has said the ET tube size 5.5, 6.5, please. I think he's asking what size of tube we use for surgery. So if I may answer, typically 5 for females, 5.5 for males.
फूल लगा दे, शुरू कर दो.
And yeah, I don't see, does anyone see any other question from the audience? I don't really see any new question. In which case, I would like to hand it back to Dr. Vijay Krishnan, Secretary of the Indian Academy. Dr. Vijay, thank you very much, all the panelists. It's been very interesting indeed.
Thank you.
Dr.
Thank you,
Vijay,
Rupal. Thank you. It's been a great panel. Thank you.
Dr. Vijay, are you there?
He's there, but muted.
So maybe then I will just possibly just thank the Indian Academy, and we can wrap up and enjoy what is left of the Sunday evening. Okay.
Yeah.
Bye-bye, everybody.
Bye, bye. Good night.
Good night.